Cue the intro music.
Yo, are you ready for this? Are you ready for this? Are you ready for this? Are you...
Welcome back to the Many Minds podcast, where we encourage collaborative community healthcare, pooling many minds for better patient outcomes. I am Alex Davis, physician assistant. Along with me always is Tyler Murray, nurse practitioner, and the two of us work together at Summit Brain, Spine, and Orthopedics in Lehi, Utah. The purpose of the podcast, the reason why we try and bring people together, is just as we stated earlier, using many minds, pooling together our efforts to create better outcomes for our patients. We want to get to know everybody's space as an advanced practitioner. What does life look like for you? How can we support each other? And what makes your specialty special?
And as a just general disclaimer, this podcast represents the opinions of myself, Alex, and any guests that we have on the show. The content from this podcast is not meant to act as a substitute for medical professional advice, diagnosis, or treatment. We're just here to chat it up and have a good time. And with that, we're going to jump into this week's podcast. Today, we're going to be talking about urology. And we're privileged to have Jamie, who we just barely got to know here a little bit and had a very good conversation to kick it off with.
I can't wait. This is going to be a ton of fun.
It's going to be good.
First thing I got to get out of the way, how do you pronounce your last name?
Peatrowsky.
Peatrowsky. Jamie Peatrowsky.
But if you ask my mom, there's somehow a U in it. It's Peatrowsky. So it depends on what part of the nation you're in.
I love that.
Yeah.
And you're Nebraska native.
Nebraska native.
All right. And you found your way over to Provo, Utah, tried to get away, and then you got sucked back in.
Somehow I got sucked back in. Yeah.
Wow.
PA school brought me here and left for 3 years. And
it sounds like the community is fortunate to have you, but the listeners will get a chance to understand that a little bit more as we get into it. But we do want to mention a cliffhanger, so stay tuned, folks, because she's got an excellent story. She's going to talk to us about patient-provider communication after discharge home from self-catheterization. So I'm interested because I worked on the 7th floor, which was a urology floor at some point, and have some familiarity with that area. But before we get to that, let's just jump into it. Alex, what do you got for her?
First off, if you had a backup plan, if you were not to work in medicine, what would it have been?
Well, I would actually probably say medicine was my backup plan.
Okay.
When I was in Denver, I thought that psych was going to be the route, kind of wanted to do sexual trauma, abuse, that type of stuff. And I volunteered for 6 weeks. I steered clear of medicine. My mom always said, you're going to be a nurse. You know, and everyone doesn't really want to do what their mom tells you to do. So I fought it for a really long time. And after volunteering for 6 weeks, I was like, this is not it. I am stressed. I'm bringing home everything. So my backup plan was medicine. And that's kind of how I ended up here.
I love that.
Yeah.
Interesting. What do you got?
Well, let's talk a little bit. Let's jump into it. So you graduated from school and right out of the gates were basically in urology. Is that correct?
Absolutely, yeah.
Tell us a little bit about that transition from graduating PA school to entering into the urology specialty.
I can't say I knew a lot of people in my cohort that were gung-ho saying, as soon as I graduate, I'm going straight for urology. How does that come about?
It was definitely not my plan. Applying for jobs, all I kind of knew was I wanted hands-on, in-office, outpatient, hospital, a little bit of everything. Mm-hmm. And I loved the mountains. I was in Denver. It took 3 hours to get to the mountains, but Utah spoiled me, 20, 45 minutes to the mountains. So everywhere I was applying at the time was an hour within mountain range. Probably meant I didn't pay too close of attention to the specialty, but knew like general surgery, GY. I kind of knew the general areas where surgery would be a possibility, urology being one of them. So I applied to general surgery trauma in Farmington, New Mexico, and a urology job in Reno, Nevada. And it ended up coming down to both financials. Financials were better in Reno, but also access to the mountains. And to be honest, I mean, I did not have any idea what I was walking into. I think you know the topics of urology, but the day I stepped foot on that practice, I said, oh, digital rectal exams. This is what I'm doing?
This is where that happens.
Yes,
oh, gotcha.
This is where that happens. This is me.
Oh, man.
Hopefully I'll be okay.
Yeah.
Well, what was that? I have to ask. What was that training like? Did they just throw you into the fire?
Mannequins
and
say, pretty much thrown into the fire. And it really was. I mean, I think I've even told. I have a couple new PAs with me, and I told them, if when you're checking the prostate, you don't know what you're checking. It's okay. I think that's normal. No one told me it would be normal to not really know what you were checking. But in PA school, we had one exam, one digital rectal, one pelvic exam. That was it.
Yeah.
So I think probably the first 5, I was like, I don't really know. Prostate's got to be in there somewhere. I'm probably feeling it, but I don't know what I'm supposed to tell anybody. And then I got called out. I was in the OR with my surgeon, and he was like, okay, do the exam. Patient's asleep. We knew he had prostate cancer, so great exam.
Yeah, good opportunity.
Yeah. I do it. I'm super confident. I give my report. He said, wrong. And I went, oh no, someone figured me out. I don't know what I was feeling. But normally, patient position makes a difference. And probably in retrospect, I was reporting it the opposite of what I was used to because he was supine instead of prone. So a little bit of variability. But man, what a learning curve. And I probably never lied ever again about what I felt or did not know.
Yeah, that's funny. I think everybody has that kind of imposter syndrome as you first get started out of school. For me, it was listening to heart rates and rhythm and murmurs in my pediatrics rotation because you've got these little infants up to 18-year-old kids. And the pediatrician always let me put the stethoscope on and listen. What'd you hear? Did you hear a murmur? Did you hear anything? And it's rare. So kind of the generic answer is, no, I didn't hear anything. Sounds pretty normal.
Yeah.
And then there were a few times like, oh, yeah, there's a murmur there. That's probably a PFO. And I was like, oh, okay, sure. I must have missed that. Sorry. But they figure you out eventually.
Yeah, they do figure you out eventually.
So you did get away from DREs solely, I'm assuming.
I did.
So tell us kind of a little bit more about what your kind of day-to-day looks like. We're interested to know urology and what it entails.
Yeah, 2 different practices. So I spent 2.5 years in my first practice in Nevada, and then I've been with Intermountain Urology for 3 years. It's a little bit of everything. So I really did wholeheartedly get everything I wanted: inpatient, outpatient, hospital, in-office procedures. My first practice, very different. Surgeons were assisting surgeons. So our primary PA focus in urology is kind of robot surgery. And with robotic surgery, those surgeons just didn't feel comfortable having anybody but a second pair of surgical eyes, and my perspective on that initially, I didn't understand. I was like, you guys can see more patients, you can have more surgeries, like you're assisting each other. Aren't you kind of like not helping yourself? And I'm willing and I'm capable. So it took about a year to get PAs into the OR in my first practice. And then it was just 2 of us. I'm very grateful to my 2 surgeons, Dr. Freeman and Dr. Canelos. Will always be my mentors that really like bared down and said, we're willing to do it. And we see like the future of it. And then rounding. So in that practice, I actually went to 4 different hospitals. So we rounded on 4. You were on for a week. You would round, do consults, do any discharging that was needed from surgical stuff, and then take call that whole week as well. Office was much busier, so it was an RVU system, so you made more money for seeing more patients. So I think 25, 28 was probably like the daily basis, and that job was Monday through Friday. Wow. My practice now is a lot different. There is no RVU structure, which was probably one of the big pluses of transitioning.
That was a good thing for you.
It's a great thing, yeah.
Oh, okay.
Not that it was hard to see 25, but it was kind of like it was a disadvantage to take time off because then your bonus was smaller.
Yeah,
sure.
Losing out on money.
Here you get PTO no matter what. It doesn't matter how many patients you're seeing. And honestly, I think it gives more time to give the real education that, as an APP, I think that's a crucial role for us is education and that patient support line.
Yeah.
So probably like 10 to 15 patients on average. Now that I've been there a couple of years, it's probably like 18 on average is my day. And I'm very surgically heavy. So we've grown quite a bit from a surgical standpoint. My first year, 100 robotic cases. We're up to 200 this year, total robotic cases. And it's a solo system. So I work primarily with one surgeon, and I go with him everywhere. So we go to Timpanogos, we go to Mountain View, and then Utah Valley.
And you're helping manage, because, we had a PA with general surgery come in and talk to us, who also, they're involved in a lot of robotic cases now. And he said, actually, it's a lot of hands-on. Like he's with the patient while the surgeons behind the
He's
robot.
he's the only one in the surgical field.
Yeah.
Yeah.
And is that the same scenario then?
Exact same scenario.
That's
So
pretty cool.
It's pretty cool. And, I'm really lucky. My surgeon has kind of pushed me in ways that I didn't expect. And so sometimes, I'm docking the robot, I'm marking out port sites, I'm kind of really acting as primary at the bedside.
That's awesome.
And of course, challenges. Are you nervous every time? Do you think, yeah, again, imposter syndrome. Like, what am I doing here? Why is he trusting me?
Who let me in this OR?
Who's trusting me with all of this?
Yeah.
But I think that's kind of like the cool part of my field. Even I was just reflecting, I help with circumcisions in the office. And at this point, I almost could do it myself. He walks out for all of the sewing. So kind of that whole finality of the case is mine, which is quite frankly one of the reasons I came back to urology. I left for 6 months, had no autonomy. And I was in a practice that had a lot of medical students and interns, so I wasn't as hands-on, and that was really challenging to say, I'll just sit and watch an 8-hour case and never touch anything. And so it's super cool. Like, our procedures, of course, I think give everybody hesitation. I think that's urology in a nutshell is like fear and anxiety. We're talking about genitals and we're doing procedures on
awkward
genitals.
Conversations, I can imagine.
Yeah. But I think that's also the beauty of it. You build these really cool relationships with patients that come to you and didn't think, my old men are the greatest example. They come and they're like, well, I wasn't going to share this with you, but 10 minutes into the visit, they're like, oh, I really like you. I'm going to tell you. Open book. We hear about everything from erection dysfunction to the ejaculatory dysfunction.
Yeah.
Not at all what the visit was scheduled for, but you made them feel comfortable enough, so everything finally came out.
I can imagine you get close to people real quick.
Yeah.
Real close, real quick.
Real close, real quick.
And I was just thinking about your inner circle, like friends and family coming to you with all of their complaints or concerns. Is that a thing?
Occasionally. I've tried to make a really good barrier, and most of the time, I'm very sarcastic in nature, so I'll be like, if you ask me these questions, you're probably not going to get the answer that you're hoping for. Or I'm going to say, all right, drop your drawers, let's take a peek. And then it's silent.
They shy
thereafter.
away from that. Yeah. It becomes less serious. It's probably not that big of a deal.
Yeah, it's a whole different thing. I have friends and family ask me about back pain once in a while. That's a little different than some of the questions you might get, I guess.
But it is interesting. I even tell some of my patients, I'm like, what's common topics for dinner talk at my house is very different than what probably any other family would be okay with. And even my significant other, he's like, my friend's complaining he's got blood in his urine. I told him he's got a kidney stone. And I'm like, see, this is what dinner talk taught you. Dinner talk teaches you all the things you need to tell.
The places you'll learn.
Yeah.
Do you feel like you practice a lot of general medicine, or is it very, very narrowed and specialized in what you're doing?
I think it's pretty specialized. I would actually say I'd probably be fearful to do some general medicine. I have a lot of comorbidities, so of course I see it. Yeah. But in terms of managing it, I would really say, surgical complications in urology I'm very honed in. General medicine, the most I get is listening to their heart and maybe finding something that I'm like, oh, if we can't do surgery yet, please go see somebody who knows more about this than I do.
What are the common things that you see? What are the common conditions or pathology that you get to deal with?
So I am very super specialized right now. My first practice was very broad, female and male urology. Mm-hmm. But now I'm primarily male urology. So prostate cancer, elevated PSA, BPH, low testosterone, erectile dysfunction, and then all of our cancers. So renal cancer, bladder cancer, and prostate cancer. And there's probably some other, testicular pain is always in the mix. UTI is always in the mix.
Sure.
Yeah.
And then procedures. How about common procedures that you do? Yeah,
so the procedures, primarily I'll assist on any scrotal procedures. So if someone has an epidermal cyst, we remove those in the office. 30-minute procedure saves the patient OR time, which is great.
Yeah.
Circumcisions. Catheterizations, I don't do as much anymore. I kind of do more of the complex catheterization. So cystoscopy with a guide wire to place a catheter when no one else can get in. And then, you're very familiar with the bladder irrigation. No PA in urology will get away from bladder irrigation for blood in their urine. Clots, catheter is no longer draining.
Gotcha.
And then all my surgeries.
Yeah.
Yeah.
Super exciting. So
I have to say,
Say.
When I worked on the 7th floor, which was initially, I mean, my nursing career started in orthopedics and neurology or neurosurgery. And then it kind of transitioned when they built the new towers at the hospital. And they decided to lump neurology with urology. And me as a bedside nurse, having all this experience in neurosurgery and orthopedic surgery, came in and started taking care of these patients who were requiring continuous bladder irrigation. And, I'd have a post-stroke patient in one room and then a bladder irrigation in another. And I didn't understand the necessity of keeping a bladder irrigation continuously running. If you let that thing go dry, it's kind of going backwards in their recovery process. And urologists just tend to not really like that.
They don't appreciate that.
Yeah. So I got some side eyes from a lot of different specialists early on, but I figured it out. But I have much respect because you really have to keep eyes on a patient in those settings. There's a lot more to it than probably what you would initially think with some of the management of that. So.
Yeah. Well, it's so easy to just think, oh, it's just fluid going into the bladder. Like we make urine, surely the catheter will drain if the irrigation isn't going.
Yes.
But, in that case, and weirdly, it's almost like I love those cases. They are challenging, but they're also so rewarding. And you maybe experience that on the floor. Like if it is clogged off by a clot, I mean, there is the stress, the annoyance of being like, oh man, is this catheter, are we even going to get it there? But then if you do evacuate all the clots, it's like the patient's the happiest in the world. You're feeling like the savior because the catheter's draining again.
It is so true because I saw on the floor, like a patient had a blockage. We weren't getting any flow. And the patients, you can see the panic on their face because their bladder is filling up and distending. And you don't want to be the person where their bladder ruptures because you couldn't get it running again. So there is some fear and panic. And then, yeah, you probably do kind of to them like, oh, you're my savior.
Yeah.
Like, it's amazing. So, yeah, I appreciate the sentiment there.
How about the correlation with the community? So I'm thinking of who are you collaborating with most commonly? What's a good patient to send to your office?
Yeah.
Or what should we kind of know about your office and what to expect in collaborating with you guys?
Yeah, I mean, I think really urology is probably playing a role in everybody's field. It probably doesn't matter. Neurology is a huge one. Many times patients after a stroke, their bladder doesn't function. And then it's kind of how long, or is their bladder even going to come back to some degree? Family medicine, I would say family medicine is probably our biggest collaborator. And I wish, as a community, maybe we could do better. I think there is a lack of knowledge, and I understand that. I mean, I speak about family medicine, and don't put me in their shoes because I won't know what I'm doing.
Yeah.
And I'm sure they feel the same about ours. But, BPH, people who can't pee, it's a huge problem. No one wants to talk about it. And that's what's crazy. These men have large prostates. Over time, they just start to say, I pee normal for an old guy. Well, no, it's not normal for an old guy. You could actually be improving it. And UTIs is your other big hitter in family medicine. Female UTIs is kind of extremely challenging, and particularly in medicine lately, the estrogen topic and lack of estrogen for females vaginally to help prevent UTIs. I would love to see more collaboration with family medicine and urology. I think the downfall is that we're so busy. It's when do we find time to actually have kind of outreach? Yeah. And Tyler at Rocky Mountain, he was like, let's have you come in. Let's teach new PAs before they're even out, what they need to know for family medicine. So I'm kind of hoping that builds something.
That's great.
Combo cases, general surgery is always a big one. We'll get random hernia patients that also have either prostate cancer or kidney cancer, and they want everything taken care of at the same time.
Yeah, under one anesthesia. Yeah, that's helpful.
Exactly. Or, traumatic abdomen, prior X-slap, and lots of scars, lots of adhesions. So general surgery has been our friend coming in. Thank goodness. They've saved our butts a couple of times. And then GY is probably our other big one. So depending on the case, even one of my surgeons recently just did a combo case with our new urogynecologist, Austin Hill, down at Intermountain. So, I think every patient probably has a urology problem. It's just a matter of the what and the when. Emergency room, how many renal masses are found in the ER for someone who thought they had appendicitis. Probably 80 to 90% of those renal masses are incidental. So it's pretty wild how many urology problems counterplay with all the other specialty.
Sure.
And
I can't tell you the number of times I've read an MRI of the L spine and they've
They talk about a renal
a
mass.
cystic lesion on the renal gland or renal. Yeah, that's
true.
So when we see that, I mean, do we just always lean on the radiologist's impression of saying, because sometimes they'll suggest, hey, this requires further workup, ultrasound, consider these. Is there any, clinical pearls you might give us in that setting, or is it just always get them over to urology if we ever see something like that?
I think you could probably, to some degree, get a second image, and especially for you guys in spine, often it's not going to capture the whole picture. I've had a lot of those, even from CT actually, where it's on the upper part of their chest and it's a upper pole renal lesion. Kidney cysts, very common. Most patients probably have a kidney cyst, but if there's any evidence that says this is maybe complex in nature, if it's big enough, ultrasound, great option. It may clarify this is just blood product cyst. We don't need to do anything about it. Or get a second, with contrast, something of the abdomen that's a full inclusive picture. But absolutely, we're more than happy to take them on. I don't know how many patients we get that we get the half image and then we get the full picture once they're there.
Yeah.
Very lucky in our field. Urological cancers are, I always say I'm kind of blessed. I love the oncology cases we have because most of them are not aggressive. They're going to be slower moving. So, even if it takes that patient 3 months to get to us, it probably is not going to be a matter of life or death because it won't change how quickly it's growing in most cases.
Oh, that's good to know.
Yeah, I know really the cases that we've really relied on urology, there's really only a couple that I can think of in our world. One is an anterior approach to the lumbar spine.
Sure.
Sometimes we'll see the complication of retrograde ejaculation.
Yeah.
And then the other common one is when we have to discharge a patient with a catheter because they're not able to urinate on their own. They can't void on their own.
Yeah.
And in those scenarios, it's a super helpful resource to have you guys available. And we just know that it's in the community and people will get great care.
Yeah.
Do you see that? Have you seen that personally, the retrograde ejaculation complications?
I haven't, actually. When you just mentioned it, I was like, I'm going to have to do some reading because I haven't seen that. We get that complaint often, but most of the patients we're getting that complaint on are on a BPH medication, which is probably number one side effect. 90% of men will experience some change to ejaculatory function. So I kind of have never thrown in that it would be anything, especially because when most of them are on the medication, that's kind of the first thought. So I'm gonna have to read.
Okay.
So thanks for that,
like
Alex.
I think the thought is there's the exposure.
It's the exposure going through the abdomen.
Yeah. And so it's interesting. And I do think it's rare, but when it does happen, boy, we've learned firsthand, you need to educate a patient about all the risks. Yes, because if they come out of surgery and that happens,
they have questions.
Yeah, it's a lot of questions.
It's all those expectations. It's amazing how far setting up expectations go. But knowing that is a risk. I can imagine you've had the other end of the conversation where it wasn't reviewed. Yeah. A patient was not too excited about the end result.
And they come in with that. So I've got kind of a weird question. I don't know if this is related to surgery. And I kind of know what's coming already. Like, yes.
Yeah.
Let's switch gears a little bit. Yeah. I want to talk about the work-life balance. You mentioned early on a little bit about it, but let's just jump into it a little more. So tell us like a day in the life of Jamie or a week in the life of Jamie. Kind of what does it look like?
Yeah, I think that in some sense could be a disadvantage of urology. It is very busy. There is not enough of us for the amount of patients in our population. My current schedule, 410s, most of that related to surgery. So, anything with surgery, I would say there's no time. Some days I'm done at 3, some days I'm done at 7, and treacherously during the beginning of my training done at midnight. So, and that was probably just part of the learning curve. That is never our goal. But start at 7, round on any patients that are in the hospital, whether that's post-op or complications, septic stone. And then office, I work office 8:30 to 3:30, and then I keep kind of that hour at the end of the day just to catch up on labs results, all of the inundating inbox stuff that none of us will ever get away from, unfortunately. And then, we talked probably about 18 patients on my days in clinic. Right now, though, my schedule has been, we've been pretty heavy this year on surgery. So I have about 1 to 2 days a week of clinic. The rest is surgery. Wow. So in a month, only about 4 to 6 days.
Wow. In clinic.
Oh, yeah. Wow. And then I do take call, but the call here is very different. So it is not weekend rounding. It is not weekend consults. I never really get called for the consult. And I'm grateful that our surgeons kind of understand why wake up 2 people when if it needs surgical intervention, I can't really do much with it.
Right.
But office call 24/7. So right now there's only we have 2 new PAs and then 1 nurse practitioner who's been with us for a year and a half. So it's just him and I right now sharing the load of call. Wow. But we decided a week on at a time kind of is appropriate. And in comparison to my first year, woo, call was not fun. Like 3 a.m. call, 4 a.m. call. Great. No sleep for the evening. But we've worked on a lot of training, triaging, and better patient education handouts to kind of eliminate some of that. And I would actually say in the last 2 years with those improvements, call's pretty minimal. I think we're very lucky. I was on call the last 2 weeks and probably 5 maybe. And that's just, my culture didn't come through. I didn't get my antibiotics, or I just removed my stent and now I have this pain. What do I do? So nothing that's too chaotic anymore.
You feel like it's manageable then?
I do think it is really manageable, actually. Yeah.
And then 1 full day off every week.
1 full day off.
So our office, our clinic, our practice, we just switched to that. So I'm interested to know, do you feel like that's a pretty good balance, having that, do you have a 3-day weekend then, or how does your...
I don't. Tuesdays are normally my day off.
So you kind of break up your work week.
Yeah. My schedule's a little weird because we do Mountain View and Timpanogos, and that's the 1st and 4th of every month, Tuesday. So I get 2 Mondays a month and then 2 Tuesdays. It's kind of like the off put.
Gotcha.
And I would even say in retrospect, I was just we tried to change my schedule to give me a 4-day weekend. So I was working 5 days, 3 days, 5 days, 3 days. Well, it doesn't work so well. Labs, inbox management. I was coming back to
people don't want to wait that long.
70 plus things on the Wednesday. So we've switched it back. I think it is a good balance. How often am I working still over my 40? Yeah, sure. Like hitting 42, 45. But in comparison to having that day off, I mean, it's great. And to be honest, I've had Tuesdays off for about 3.5 years now. My job before this, I had Tuesdays off as well.
Oh, so
and even though it's in the middle of the week, it's kind of nice. Like
get things done.
Yeah. And then those 3 days that you come back, you're like, cool, it's 3 days and I'll be done on to the weekend. So
that's a good perspective.
I love that.
How about in relation to compensation and pay? Do you feel like urology as a specialty in general is in the forefront and compensating well, or is it by the state of Utah? Or and you mentioned earlier that previously you were on an RVU and now it's more of a salary.
Yeah.
How do you...
So I probably
that?
go into pretty good detail. My first practice, everyone starts at the same base rate, so 120, which for a new grad, I mean, I think that's
good.
That's pretty high, and that's 6 years ago. So like really high in my opinion for 6 years ago. And I didn't really understand the RVU concept, and there are some pros and cons to it, but we would get a bonus every quarter. So you had a baseline RVU, you had to meet whatever that number was, and then anything you made over that baseline was your own bonus. So when I left that practice, I mean, my bonus was $20,000 in 1 quarter.
Oh, wow.
So if you calculated, and granted, that's seeing a lot more patients than I'm seeing now, but if you calculate that, that's an extra $40,000 in half a year.
Yeah.
So, you're making 180.
Yeah.
Which is pretty nice. So big benefit, I think. And Utah, I took a pay cut to come here. I knew I would do that in coming here. I was willing to take the trade-off. I came in, I think at 119 was kind of the number. And that was with 3 years of experience. So yeah, definitely a little under where I would anticipate. Differences though, private practice was my first job. This is hospital medicine, and we all know Utah has a lot of medical providers, which I think to some degree hurts us because someone will take it for less money if you're not willing to take it. I've pushed a lot. I would say I'm a big believer. I was just listening to someone else on your show and they talked about, asking for more. I don't even think it's about asking for more right out of the gate. I think it's at all points of your life that you are in medicine. If you know you are doing something that's above and beyond, ask.
Yeah.
Because one raise a year that's 50 cents, is that really worth anything to you? But, I'm very lucky in my situation right now. I was just calculating without call. I think 160 is kind of where I'm at. And then if you add call, because we do get paid for office call, it's only a percentage of our annual. But last year I was close to 200,000 with call.
Wow.
I was the only PA taking call last year, though. So that's also
a lot then.
equates to,
Yeah.
But again, in limiting how many calls I was getting, it really wasn't horrible because we made big improvements in clinic. But I think, I just talked to my significant other about that as well. When do you ask and why do you ask and what support do you have behind you to ask? But the worst thing you can hear is no. Mm-hmm. But if you don't ask, you don't even hear no.
It's true.
You're just stuck.
You don't even open that door.
Yeah. Stuck stagnant with what you're wanting. And that's where I would just even, my case is kind of interesting. Last year, I had asked for a raise. I said, I've done this many robotic cases. I think that I deserve more. I know you're bringing in new grads at a higher rate than you brought me in at. Like, this is just how the world works. I could leave and make more money doing the same job somewhere else. And they had told me, no, we ran the numbers. Everything's fine. 6 months goes by and find out that actually there was a discrepancy, that they had been underpaying me for over a year.
Oh, my goodness.
And that the raise wasn't there. So had you not asked, and, I think there can be hesitation to say, well, I asked 6 months prior. I don't want to look greedy. But had I not asked,
at least have the conversations.
Yeah.
Open the door.
$5 on my base rate.
I also think to that end, it's understanding your own worth to the clinic or practice. And I think that involves some transparency and also asking questions and knowing what you're bringing in for that individual commodity, I think is important.
Yeah.
But there's the financial side, but there's also just the impact that you have, like you mentioned, where you could have, rather than having a surgeon and a co-surgeon, you could be the first assist. Right. That other surgeon could be filling his or her time somewhere else, making a lot more money. And so I think all of it translates into that. So I'm glad you said that, though. I think that's good for people to hear, is having that conversation about your own worth and opening those doors, if you will. So I love that.
I think sometimes just as a female in general, I would speak to that a little bit. A female, we often are just kind of expected to take what we're given, and that I think it's a second facet in medicine as a female, to understand your worth, but to also be okay to negotiate. And I just had a friend of mine say, well, a man would be asking for more, so why are you not asking for more? And that's not necessarily to bring gender into it, but I do think that on both ends of it, you have to know your worth. You have to know why you're asking for it. And if you have that, then there should be zero hesitation.
Yeah.
And you've got to be able to say, if they say no, cool, they said no. But at least you brought your case forward.
That's right.
Yep. Yeah, and I think that's the key point there, is you got to have something that tangible that you're bringing to the conversation of what it is that your value, like how do you equate your value?
Yeah.
So something tangible, I think, is helpful to have those conversations.
Have people run the numbers. I mean, I have my robotic guy run how many cases we do every year.
Yeah.
There are plenty of ways to get data. It takes extra work, but the extra work pays off most of the time.
Paying attention to the details. Yeah, I love that.
Have you ever looked at the gender discrepancy as a nurse practitioner?
I have not.
In the PA world, I'm pretty sure the last I saw it's 60-40 female heavy.
Yeah.
It's slightly higher female.
Even from a pay perspective, or just
just the numbers, just how many people are employed as physician assistants or physician associate.
Yeah.
Slightly heavier, more females.
I could only imagine it's female dominant in the nurse practitioner space, but I don't know.
Yeah.
Anyway.
Even when I went to PA school, I actually think it was even more. It was like 70. It was greater, like 70-30. Like, I mean, our class was one of the first that was almost a 50-50 split, I think. Which we were only the second cohort, so that doesn't say that much. But it was 50-50. So.
True. Okay. How about one of the last topics we like to talk about, just urology in general. What is something new, something innovative, something exciting, new technology, new procedures? What is coming down the pipeline in the world of urology?
Yeah, I would say, coming down the pipeline, at least for us, single port robotic. So right now, all of our robotic cases, 4 ports, 2 assist ports that I work through. And robot has grown so much. Even when I first trained, the robot didn't do what it does now. I trained on the SI, and now I'm on the XI. They've got DVI 5, so robotic 5, which has some feedback, which doesn't play much of a role for, the assist. But I think single port is going to be really interesting. It allows for one large incision to do everything. And the cases I've watched, we are not privileged enough to have a single port. We've been working on that for the last year.
Yeah.
But, if someone had a prior XLAP, we can use this and kind of go pre-peritoneal to get the same access, or even for prostate cancer actually coming directly into the bladder. So one single incision. I think it's a cool pipeline that's coming, but I also, I guess, question, is bigger incision. How's the recovery?
I was thinking of that because I feel like the trend is the opposite of less invasive, smaller incisions.
Yeah. I question part of it is maybe getting rid of the assist role because there won't be as many instrument change. It's kind of all ported into one location. But the outcomes that I've heard at conferences are equal, same, nothing has changed, and patients are still spending 24 or less hours in the hospital. So, I mean, I couldn't believe actually when I heard the surgeon present, he was like, I've been sending patients home for about 6 months now after single port robotic.
Oh, wow.
So I think that is really cool. I would just say robotic in general for urology. Not that there's anything new with that. Urology was kind of one of the frontliners for robotic. But, for BPH, if you have a prostate that's over 100 grams, we can do what's called a simple prostatectomy. So like an orange, we leave the peel, we take the fruit. The fruit is the problem. These patients used to have to spend 1 to 2 plus days in the hospital for irrigation, continuous bladder irrigation, because it's a bloody case.
Sure.
Advancements for us, we now do them all on a Friday. We do 6 between 2 robot rooms. We kind of flop, and everyone's going home the same day.
Wow.
Very cool.
So it's super cool, and the reports afterwards are always my favorite. These guys come back and they say, I'm peeing like I was 20. I have no idea. So, you can't get really better than saying I'm 20
Highlight
years
of the
old
day.
again. Yeah.
Love it. How about, this is my favorite, Tyler was teasing earlier. I'm excited to hear the rest of this.
Oh, man.
A patient's story apparently involving some communication after being discharged and having to self-cath.
Yeah, so this poor patient, he had this simple prostatectomy done actually, and was doing relatively well, but 3 weeks in, kind of challenges going backwards, weak stream, peeing all the time, couldn't hold anything. And he went to Mexico and unfortunately got super tortured in Mexico because there was a stricture of some sort. So narrowing somewhere in the urethra, and without any medical reports, we don't really know what that means. So he kept his catheter in for a little bit longer, came back, and my surgeon ended up doing a cystoscopy on him, but couldn't actually do the cystoscopy. So he had meatal stenosis, narrowing of the meatus itself. So really just that distal tip of the penis, nothing more. And we can avoid big procedures if a patient can catheterize themselves. And in this case, man, super lucky because he doesn't have to slide the catheter all the way up, just has to go about, maybe even a centimeter, not much.
Yeah.
He has access to the patient portal, and he emailed me week after. He said, Jamie, I don't know. I don't know if I can do this. My penis is super sensitive. I'm dreading all of this. Like, are you sure I need to do it? And I said, well, this is that benefit of having the portal. I said, if you can do this, we hopefully avoid another procedure. I don't need you to slide it in all the way, but I need you to at least just get past the tip. And my favorite part of it is just patient's dynamic with you as you reply. He came back and he said, okay, I think I can try. And I'm pretty sure I know I'll get through it. The final email I got was the completion, and he had been able to perform it. But his response was, my little guy keeps disappearing into my testicles when I try to do it, and the catheter is quite slippery. I think there's a lot of fun in my practice because it's stuff that you got to walk people through that you never imagined having to walk people through. But also, I think he was pretty proud of himself that he, with my verbal assistance, was able to complete it, even though his little guy was disappearing on him.
That's awesome,
man.
Fun conversations.
I love it. I appreciate you sharing that.
Probably a little bit different inbox than we get.
Yeah.
Different questions.
Yeah.
Yeah. We get a lot of references to little man.
Oh, I'm sure you've heard it all.
You want to, I have one more for you that I think you'd find funny. This was an after hours call.
Okay.
It was a little old lady, and she had a kidney procedure was supposed to have a stent on strings so she could remove it at home at some point. Calls after hours, and most complaints after this, if the stent slips, they'll just pee their pants. Like, there's no control. It's past the sphincter. Like, it is full incontinence. So I figured it was clear-cut call. But no, in fact, she is not leaking her pants. She is worried that there is something down there. And in fact, maybe it's a creature that got down there, and she is scared to look for the creature.
Oh my goodness.
So on the phone, much harder, and she's 3 hours south. So
Use the string to get it.
There's no monsters in the closet.
There's no monsters.
Just open and look. There's no monsters.
It's probably the string. So I walk her through, get a mirror. It's just toilet paper.
Oh, okay.
And so she was so embarrassed.
Yeah.
But I'm so grateful, that you can walk people through.
There's a creature down there, and I'm afraid to look.
Okay. That's awesome.
Love that. Yeah.
Perfect. Jamie, this has been a blast. This has been fun.
Thank you guys for having me. This has been great.
Tyler, what'd you learn today?
My goodness. The world of urology. I did not know many of these things, even having worked on a urology floor. I have much respect for your specialty, and I can see the need. And I think hopefully for the listeners, they've kind of been able to listen to exactly what you do. And I think what you do is pretty widespread. I mean, you're seeing patients in the clinic, you've got hands-on in the OR. There's a lot of autonomy, and I'm always an advocate for autonomy. I love autonomous work. So yeah, I definitely a newfound respect for the space of urology that I didn't know coming into this. So really appreciate the time you've taken to share your specialty with us, and for us to be able to get to know you. And now I know who I'm going to call every time we have a difficult catheter placement. I'm going to be like, yep, Jamie's the one. She's got
Please do. Please do. We are happy to help always.
That's awesome. How would people connect with you, Jamie? If somebody had follow-up questions or wanted to get to know you better, or find your clinic, how would somebody reach out to you? Social media, email, what's the best?
Social media, I am on social media. I think it's pa.jamie. And then, my office number, anyone can always reach out to me on my office. So 801-357-3242. That's Utah Valley Urology. And then I would say reach out to me on via work, and I'll be happy to give out my personal email if needed. But otherwise, plenty of people in the community already have it. I'm sure Tyler Summer has referenced, who invited me to this podcast, is willing to give that number out to anybody.
I know, it's funny. Somebody mentioned that I'll just give my cell phone number because apparently everybody else already has it. I don't know how, but it turns out to be that way sometimes. With our clinic, we can be reached on social media as well. It's Summit Brain, Spine, and Orthopedics. Our YouTube channel is Summit Medical Institute, and we like to see people in person every Tuesday morning. We do an interdisciplinary case discussion rounds presentation at the Mountain Point Hospital in Lehigh, Tuesday morning at 7 a.m. We want to see everybody there and help collaborate with us. We'd also love to hear from people that are listening. If you're out there, give us some feedback. Let us know what you like, what you don't like, what's working. Who should we have on the show next? What specialty do you want to hear? What questions should we be asking? And how can we improve the show? We'd love to hear from our guests. Anything else?
You normally wrap this thing
I
up.
know. Okay, fine. We'll hit the outro music, and we'll see you next time. This has been the Many Minds podcasts, where we're using many minds to collaborate for better patient outcomes. I'm Alex Davis.
I'm Tyler Murray.
We'll see you guys next time.
Adios.
Are you ready for this? Are you ready for this? Are you ready for this? Are you ready?